Hey, I would like to welcome everyone to the Integrative Diagnostic Medicine Case Conference. We still have about 30 seconds until we begin the conference, but I thought I'd just log on a little early and say hi to everyone, and thank you for joining us. I think oh, it just hit 3 o'clock. It's time to start the conference. There's a lot of reasons for people to be late to a conference. I'm late sometimes. It's unavoidable. This is clinical medicine. However, I've always been a big believer in never penalizing those who are on time, even early. And so I'd like to start on time. It's 3 o'clock, so let's start. Welcome again, everyone, to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for May 29th, 2020. And this has become our regular time. Again, if you're on the West Coast, California, this is Lunch and Learn. If you're here on the Third Coast, the Gulf Coast, or the East Coast, it's happy hour. And if you're in Europe, like several of our participants, this is basically bedtime stories. Well, what better way to start your weekend, regardless of where you are, than Adventures in Neuro-Oncologic Diagnostic Medicine? Okay, we always like to do a warm-up, so let's get started with our warm-up. And for today, I've chosen a genomic alteration instant pattern recognition. All right, so the question for you is, what is the genomic alteration? Now, everyone's muted, but you can respond with the chat function. So you can just type in your chat, whatever your answer is, et cetera. As the conference goes on, I can see those on my screen. And it's good to commit, to step out there, put yourself out there. All right, so here's, are you ready? What is the genomic alteration? Go. I'm going to wait for a second. Something to pop up, and everyone taking this in. Okay, we'll give a little hint. Here, I will label the sequences. Here are the sequences. All right, Dr. Harb, IDH mutant. IDH mutant is good because it's in the frontal lobe. More specifically, that's correct, astrocytoma, IDH mutant diffuse astrocytomas. Why? Why do we know it's IDH mutant? And that is the mutation. Absolutely. That was a perfect answer because that was what I was asking for, not the diagnosis. Perfect. How do we know that this is an IDH mutant diffuse astrocytoma before we're even called up to the frozen section suite? Right again, Dr. Harb, T2 flare mismatch sign. This is a positive T2 flare mismatch sign. Dr. Gilbert also chimed in on that. Perfect job. Notice that the T1 with contrast shows it's non-contrast enhancing, and that's the setting in which we look for the T2 mismatch sign. And for those who may not be familiar with it, T2 flare mismatch sign is simply when you compare the T2 with the T2 fluid attenuation inversion recovery, which suppresses normal water. And what you see in the positive mismatch sign, as you can see with the asterisk, is that the hyperintense central zone of the lesion becomes hypointense or is suppressed with a residual hyperintense rim on the T2 flare. That is a positive T2 flare mismatch sign. And in an adult, we're not talking about pediatrics, there are many exceptions in the pediatric tumors, in an adult, in the context of a diffuse astrocytoma, so we're not, you have to know it's a diffuse astrocytoma, and you can know that for several reasons, T2 flare invading the cortical ribbon up to the T2 flare invading deep gray basal ganglia thalamus, et cetera. You can strongly suspect it's diffuse glioma. So in the context of an adult diffuse glioma, T2 flare mismatch sign is virtually 100% positive predictive value for diffuse astrocytoma IDH mutant. And that, in fact, is the diagnosis. Now, this is basically genomic alteration, instant pattern recognition 101 for this group, because I know I'm talking to a very sophisticated group of people. All right, quick question, follow-up question. What other two pieces of data that I have already given you fit well with the diagnosis of diffuse astrocytoma IDH mutant? What were the two pieces of data that I gave you that mesh really well with this? And the answer, the age, 38, young adult. Young adult fits well with IDH mutant disease, and the anatomic location. IDH mutant diffuse glioma disease with astrid oligo is overrepresented in the frontal lobe. Certainly can occur in other lobes, but overrepresented in the frontal lobes. So this is a very classic case. All right, so if we look at, we have three data pools, all right, and that is age, anatomic location, and imaging characteristics. So what we're talking about is a Venn diagram model with three data spheres. Each data sphere has its own differential diagnosis. And in this particular illustration, we know the patient's age. This could be infant, young child, older child, adolescent, young adult, middle age, older adult, right? These are the major categories, and the differential diagnosis changes with each one of those major age demographics. Imaging features, obviously this is very broad, and depending on the features, very broad differential. And then the anatomic location, clearly the frontal lobe is quite different from interventricular, pineal region, cellar, supracellar, etc. So we look at the overlap of these. What we have is young adult, 38 years old, frontal lobe anatomic location, and T2 flare mismatch sign, positive sign, and the overlap zone there in the center. That is where the very narrowed differential diagnosis will be. And with even more, sometimes 3 data spheres is all you need to get to the answer. All right. And in this particular case, that's it. Diffuse astrocytoma IDH mutant. So this is a very simple 3 data sphere Venn diagram model. Question: what does the Venn diagram data sphere model look like in the year 2020 for our more challenging cases? Answer: this is what it looks like. 8 data spheres with an octagon with the quote the answer, or at least the narrow differential in the center. Each one of these spheres has its own differential diagnosis, whether you're talking about age or anatomic location. There's going to be a list of tumors that are characteristic for that age, for that anatomic location, etc. And if we overlap all of the data spheres for the particular patient that we're considering, the answer, the most precise answer, which is the diagnosis, should lie in that octagon in the middle. I love that analogy of the octagon, right? That sounds like MMA, mixed martial arts. The octagon, it's a battle, it's a war. And that, make no mistake, that is exactly what we are engaged in. It doesn't matter if you're a diagnostic radiologist or a surgical pathologist, we are in a war, and it's going to be up close, and it's going to be very personal, and cancer, nature is going to try to take you down at every turn with misdiagnoses, and that is why we want to apply this 8 Venn diagram model and be critical, be skeptical. All right, there's a diagnosis in the center. All right, let's take a quick look at the 8 data spheres, all right, the 8 different spheres of differential diagnoses that we're going to overlap. Typically, we start with age. That's one of the most basic pieces of information we know. Differential diagnosis, obviously, for a child, for young adult, older adult, is going to be very different. Gender, clearly, many tumors more common. Brain tumors in general are much more common in men, but of course, in women, breast cancer more common than in men, does occur in men, more common in women. Meningiomas, more common in women. The single brain tumor, I've said this before in the conference, most overrepresented in men and males would be germinoma. Oh yeah, hugely overrepresented, particularly adolescent males. Gender, very important. Clinical history. Now that sounds so vague and nebulous. It's not the entire clinical history. It's not this big electronic tome. Frequently, it's 1 or 2 pieces, specific pieces of the clinical information that are the key, and that's what is in this sphere. All right, it could be as simple as 4-week history of headaches, nausea, vomiting, papilledema. That is huge. It could be 15-year history of intractable epilepsy, seizures, which has not been worked up by imaging, et cetera. It could be something like gelastic laughing, gelastic seizures. All right, which you're going to try to localize that to the hypothalamus, the mammillary bodies, the tuberous cinerea. All right, probably a hypothalamic hamartoma. That's what we're talking about, the clinical history, very specific. Anatomic location, we've talked about that frequently in this conference. Imaging characteristics is more than just the anatomic location. Does the tumor enhance? Does it not enhance? Is it diffuse? We would also include perfusion metrics, all right? Like the relative blood flow, volume, all right? All of this will be in there, and we'll be talking about some of these other imaging techniques and results as this conference series goes on. Histology. All right, well, this is where typically the pathologist comes in, and we're supposed to be the masters of histology. We'll look at that a little closer in one of the cases today. Differentiation markers. Typically, we would do this by immunohistochemistry using polyclonal or monoclonal antibodies. Gives us an idea of the differentiation lines of the tumor. And then finally, the 8-sphere molecular signature, and we are 4+ into the era of molecular signature as a routine part of our work in 2020. All right, again, overlap the data for any given individual patient. plug in this data, you should arrive at a very specific diagnosis in the center of this Venn diagram. Now note, all of the information that you need to populate each of these 8 data spheres is readily available to all of us through the electronic medical record, or electronic health record, if you like that term better. All right. The problem is in getting the pathologist to take advantage of it, particularly the imaging characteristics, which are absolutely critical. And we talk about this a lot. Okay. Without doubt, the 2 most rapidly evolving data spheres of this 8 data sphere model are going to be molecular signature and imaging characteristics, and they are evolving in parallel. Again, pathologists tend to be very good with molecular signature, staying up to date, all these conferences. They tend to be very weak with imaging characteristics. The imaging characteristics is applicable to every subspecialty, not just neuro and bone, although neuro and bone have featured them for a long time. Okay, so that was a little warm up. Why don't we do, that was a genomic warm up. Let's do a histology warm up. Okay, I'm going to ask you 3 questions for this warm up. The first is going to be, what is the pathophysiological process that's illustrated by the image I'm going to show you? The second question, what is the molecular surrogate immunostain that I'm going to show you? What's the immunostain, molecular surrogate? And the final question, of course, where we all hope that where we hope to end up, what's the WHO 2016 diagnosis? Okay, everybody ready? All right, here it comes. First question, what is the pathophysiological process going on? And here it is. This is the immunostain, and I'm looking for a pathophysiological process. This tissue, this immunostain is speaking to you, and we're not talking about molecular signature yet. We're talking about biology. You don't even have to think about the molecular signature yet. All right? Yeah, Dr. Gilbert says a diffusely infiltrating lesion. Where? Diffusely infiltrating where? Where? Where is it diffusely infiltrating? How can you tell from the pattern, the morphologic pattern? In the cortex. That's right, Dr. Gilbert, or maybe the basal ganglia, maybe the thalamus. All right? Why don't we say gray matter? All right? Here was the hint. All right? This is the H&E of that same field, or a similar adjacent field. All right? And what you're seeing, all these things in the center, and let's go back. And now, having seen, all right, let's go back. Let's look at the H&E. Do you see the second cellular constituent, the big guys that are standing out? Now let's look at our immunostain. Do you see how there's clustering around all those big guys? All right, what's labeled here are neurons. You recognize them because they're large. These are projection class neurons, central nucleolus, nissal substance. These are big neurons, ganglion cells. Look at the big black nucleus in the center of the clusters. Everyone see the clusters? There is no doubt there's diffuse infiltration of the neuropil in between the neurons, but there are also a pattern of clusters. And the question is, why the clusters? And the clusters, that's correct, Dr. Gilbert, perineuronal satellotosis. This is secondary structures of Shearer, right? And this happens whenever a diffuse glioma infiltrates, or frequently happens when a diffuse glioma, either astro or oligo, infiltrates gray matter, either the overlying cortical ribbon or the deep gray can be seen there too, right? And this is a key feature of diffuse gliomas. It's one of the things that tells pathologists that to put diffuse glioma, infiltrating glioma, astro oligo at the top of your differential diagnosis list. Now look, the first point of this slide is you do not have to have an H&E slide to recognize basic H&E pathology, basic processes. This is an immunostain. I could have shown you a stone cold negative, hematoxylin only, negative immunostain, or a control for an immunostain with just hematoxylin, and you should be able to see the satellotosis, right? And pick up that that's what's going on. Think outside the box. You can't be so limited that you only recognize a thing in one of its manifestations, right? All right, and that you can develop that ability. All right, what's the pre-op imaging look like of this area? This piece of tissue, where it was taken from, describe a key or hallmark feature of all of the pre-op imaging sequences, MR imaging sequences. What would it look like? All right, and I think pretty much everyone knows. I mean, this is a point we make all the time, is that pathology is imaging, imaging is pathology. So listen, when an oncologic neuropathologist, all right, looks at this slide, do you know what he or she sees? This. We see diffuse infiltration, that's right, Dr. Cathcart, T2 hyperintensity infiltrating from the white matter into the cortical ribbon, blurring the gray-white junction. All right, so we're talking up here in this area. Look at the contralateral side. See how you can easily see the difference between the gray matter and the white matter, that distinction? It is totally blurred, totally lost in the infiltrating tumor side. And again, that's a hallmark of diffuse gliomas. All right, next question. Molecular alteration surrogate immunostain. What is the immunostain? You absolutely can get this. Okay, Dr. Harb, we've got P53. P53 is an interesting guess. P53 because you see nuclear. All right, I think Dr. Cathcart just says ATRX. Yes, Sergio, ATRX, ATRX. Esther Bediven, yes, ATRX. ATRX seems to be winning. Good job. Why? Why do you know it's ATRX? One key, okay, let's make the observations for all of you. I know we have a lot of probably neuroradiologists listening that can't quite get there. Dr. Gilbert is correct. The neurons is the answer. All right, and Dr. Cathcart says the same thing. All right, Sergio says the same thing. Let's walk through it, shall we? All right, here we go. This is the reasoning process. Two observation. The immunostain that we're looking at is labeling normal neurons and the tumor, neoplastic glioma. So it's a marker that is present in both normal and neoplastic cells. And it's labeling actually all nucleated cellular constituents. In other words, if we had seen, I didn't have perhaps a good example of a blood vessel in this slide, but the endothelial cells would be labeled, smooth muscle would be labeled, microglia would be labeled. If there's any reactive lymphocytes, they would be labeled. The only thing that's not labeled, nuclear, would be the red blood cells because they're not nucleated. All right. In humans, I know that's specious of me. Yeah, in humans and other mammals, they are nucleated, and they would label in that instance. Which a mental note. Have a slide of ATRX K9 in the future. Okay. So noted. Let's keep going. If all normal cellular constituents are labeled, the target epitope must be normal. Look, if it's labeling the normals, all the normal cells, it has to be normal, meaning that the antibody is not looking for a mutant pathogenic protein, all right? It's looking for loss, all right, of a marker. Okay, and thus, being a molecular alteration, the immunostain must be interrogating the tumor cells for loss, what I just said, and thus this stain, this ATRX, is a negative result for the molecular marker that we're looking for. We're looking for loss of ATRX. It's not lost, so in that sense, we do not have evidence. We have no evidence. In fact, we know that the ATRX is retained. We deduced all of that just from the pattern, just from the histology, recognizing the neurons and endothelial cells. If you had the whole slide, you could look for blood vessels and meninges, that this was a normal protein and it's not lost in the tumor cells. All right, so to summarize, all right, two observations. Diffuse glioma, aster or oligo, based on secondary shear formation. We got that far just by seeing the secondary structures of shear, perineuronal satellotosis, the others are perivascular satellotosis, subpeel accumulation, a band of tumor cells in the otherwise hypocellular molecular layer. Those are three of the most important, or shall I say clinically useful, of the 8 secondary structures that Dr. Shearer described. All right, second observation, normal nuclear and cytoplasmic cellular constituent. Oh, say, now this is a different Venn diagram sphere. If you wanted to break it down that way, for differentiation marker, for molecular marker, what are all of the immunostains? Listen, what are all of the immunostains that you can think of that should label an epitope, all right, an antigen you're going for in the nucleus and the cytoplasm? And there are a bunch of them. Nu-N would be a great one for the neurons, right? It stains nucleus and cytoplasm. S100 protein is another good one. But Nu-N obviously should not stain the tumor cells. All right, so the third piece, it's actually 3 observations. All of this that is not lost in the glioma cells. All right, thus, the antibody is directed against a normal cellular constituent that is strongly expressed in nucleus and also cytoplasm, which must be retained in either diffuse astrocytoma or oligodendroglioma, but lost in the other. Why? Because that's the reason why we're doing the immunostain. The whole point in performing it is because it must be important whether it is retained or lost. Otherwise, you're running it to what, for revenue? To support the lab, bring in money? That's not only immoral, it's illegal. So there has to be a reason for running the immunostain, right? And in this case, it's to help us distinguish between astrocytoma and oligodendroglioma. So here are the key words in that summary statement, normal nucleus cytoplasm, retained or lost, whatever. That narrows it down to ATRX, and that is a beautiful job, all right, of deductive reasoning to get, look at this is so gorgeous, to get all of this from one screen capture, one image of ATRX staining in a diffuse glioma in the cortical ribbon. So what is your diagnosis, all right? Do these sequences help? Do these sequences, what I'm showing you here, T2 and T2 flare, do they determine the diagnosis? Yes or no? And the answer is no, just based on this, no. Why? Because this is a negative T2 flare. All right, see how on the T2 flare, the center is as bright as it is on T2, it's actually brighter. That is negative, all right? No, it doesn't determine it on its own. Why? It's negative for T2 flare mismatch sign. The positive predictive power, that is if the T2 flare sign is present, which is suppression or hypointensity of the T2 hyperintensity on the flare sequence, its predictive power is about 100%. For what? For diffuse astrocytoma IDH mutant, all right? It could be a 2 or 3. But the negative predictive power is very low, all right? In fact, we would consider it non-contributory. What does that mean? It means that based only, listen, based only on the T2 and the T2 flare that you're looking at here, this could be an astro or an oligo, right? We have to use the molecular signature. We have to use the ATRX, all right? ATRX protein is retained. Thus, the glioma does not display the classic molecular signal alteration triad of diffuse astrocytoma IDH mutant, all right, which is IDH mutation, TP53 mutation, and ATRX mutation. Therefore, as I know several people, it's popping up on the screen, good job. This must be an oligodendroglioma IDH mutant and 1p19q co-deleted. I say it must be, that must be or should be #1 at the top of your list based on all the data we have. And remember, our differential diagnosis list is not random. It's based on the statistically most likely, meaning most common, most frequent entity based on the data that you have. And as the diagnostic process goes forward from our initial encounter with the patient, which the first thing we usually know is just age and gender, and we go from there, the differential diagnosis shifts as we add additional Venn diagram data spheres diagnoses, right? Okay, there's always a differential diagnosis. Can you anticipate my next question? All of the data, listen, all of the data that you have would also fit a different diagnosis, all right? But it is rarer than oligodendroglioma for this constellation of data spheres. What is it? What else could it be that would be congruent with all of the data? That is that ATRX is retained. There's no loss of ATRX. It is non-enhancing. It is a diffuse glioma. There's satellotosis. Any guesses? Any ideas? It could be diffuse astro 2 or 3 IDH wild type. All right. All right. It's fine. Sorry. let's digest that for just a second. There's actually, I should have included one more. There's one more thing it could be. Now this is rarer. That's why it's second. Everyone capture that. It would fit. Now the diffuse astro IDH wild type evolves rapidly, will evolve rapidly to glioblastoma. That's what it would predict. The other possibility, although the patient is getting a little far out on the age demographic, it's still absolutely with young adult could be astrocytoma G34RV mutant. It is the hemispheric equivalent of diffuse midline glioma H3K27M. Yeah. All right. Now, if you did not know anatomic location, it could be either one of those. If all you had was the molecular data, yeah, everybody got that? Oh, this is the beauty. You know, this is what we're talking about now. Now, you may say this is so totally artificial because I have everything when I look at a case. No, you don't. You don't have the cases where you don't have imaging at all. Sometimes you may not have you may not have molecular signature at all. These are cases coming from the outside, tiny, cauterized biopsies, et cetera. You're going to have to learn to squeeze, to deduce logically, soundly, every bit of diagnostic evidence out of every piece of information that you have in order to survive and construct a differential diagnosis, beginning on top with what is statistically most likely. But there are many examples With frequency, it won't be number one. It may be number two, it may be number three, and that's why you always must have a differential and not lock yourself only into the most statistically likely, or you're going to get burned so bad you're going to lock up because you don't have the backup plan when the 8th sphere of data totally contradicts the first 7. Then what do? If you've constructed a differential, you move to number 2. Okay, you like that? Yeah, that was an exercise, a useful exercise. We're just warming up. Okay, let's move on to spine metastasis challenge. Okay, I don't think we've covered spine yet in the COVID era of conferences. So let's take a spine metastasis challenge. Ready? I want to know your diagnosis. What is your diagnosis? And remember, always in this conference, always guessing will be severely penalized. And what is the penalty for guessing? It doesn't matter. If you're right, if you guess and you're right, we don't give you a prize and move on. You have to explain it. Yes, that's exactly. You have to explain it. So why? You're going to have to explain why. Ready? Here we go. What's your diagnosis and why? I'm gonna pause just for a few seconds here to let anyone chime in with the chat. What is your, now this is spine. All right, we're talking about spine lesions, all right? And you're looking at this spine lesion, and I want someone to make a guess, take a stab at it, using all of the information. All right, I've got adenocarcinoma. Yeah, that does look glandular. That does look like adenocarcinoma. Can you please be more specific and tell me why? Why? Are you analyzing all of the data, or are you only looking at the upper left half of the screen, which shows what looks like adenocarcinoma? All right, this area. Are you paying attention to this bottom area at all? Do you see any tumor cells in this bottom area at all? No. Like this? No. Did you think that this was mucin? Why is there no mucin up here? None at all, 0. So we're separating the mucin from the tumor, all right? I think Sergio may just have gotten it. These things go by so fast. It's on my little screen, the laptop. So I apologize for not catching all the guesses. Anybody want to chime in? What is that stuff in the lower right, and how does it help you narrow? It doesn't have to be absolute, but narrow the diagnosis greatly. What is that stuff? That's called PVA, right? We're talking about iatrogenic arterial embolism, iatrogenic, physician-induced. The physician, the interventional radiologist injected this. Why? Because the lesion was the metastasis was highly vascular, to decrease bleeding, to decrease the problems, technical issues for the neurosurgeon, and the number of units transfusion that would have to be used. All right, this is PVA, polyvinyl alcohol. It's very recognizable if you know what all the different elements look like. This is just one of them, and guess what? Pathologists can recognize all of these different types of embolic material. And we have to stay current with the literature, just like with genomic alterations, et cetera, because there are new agents and flavors, variations of embolic agents and in situ hemostatic agents that are created all the time and come on the market. We have to stay up with them, right? But again, that's part of the challenge and the excitement of working in this field. So that's PVA. All right, it's highly vascular. It could be melanoma, highly vascular. It could be renal cell, but you know, the H&E of that looked like adenocarcinoma. So you think, what tumor would look like adenocarcinoma, but be vascular enough? Do we usually embolize regular adenocarcinoma lung? No, because it's not that vascular. Thyroid is #1 on your list. This is not pathognomonic. Don't get me wrong. Remember how the conference works. When I ask for a diagnosis, I want to know #1 on your list, right? Based on the data. That's what I'm asking. So you know that preoperatively, the clinicians, the primary care physicians, we're clinicians, the primary care physicians knew the diagnosis. They knew it was going to be highly vascular. The imaging says it's going to be highly vascular. So they embolized it. That is huge to the pathologist to know that in terms of helping you and helping you be prepared, even if you didn't know the history. And you will face that scenario with the outside cases. Or what about patients who present with spine metastasis, all right, as the initial presentation? It is a significant percentage of patients, as we learned from Dr. Tatsui in his excellent conference, the clinical conference with his colleagues last week. All right, this is the same case. And here we're actually looking at the metastasis and axial and sagittal sections. And you can see that I've drawn the lines, the cross-plane, the lines to show you approximately where the sections were taken. These are all T2 weighted signatures. Remember the rule of thumb, T2, H2O. T2 visualizes water as hyperintense. All right, and you can see the middle panel is going straight through the metastasis. How does that middle panel, besides having a mass that is difficult to see, on the T2, how does that mass, the vertebral metastasis, the whole picture, how does the picture differ between the three? It's like, which one of these does not belong? Well, it has to do with the Bilski grade. So again, for those who attended Dr. Taksui and colleagues conference last week, what is the answer? What grade is it? I'll just wait just a second to see if anyone just knows the Bilski grade. It's based on that middle panel, and you can compare it to the other two. What's the difference between the middle panel and the other two? There's no CSF in the middle panel. You see no CSF. All right. Yes. Ashley Arrow, exactly correct. It is a 3. This is a Bilski 3. All right. Yes. Clinical grading schemes. We need to go through it. Let's do this. All right. Here's a great paper. This is J Neurosurg Spine. One of the papers authored by Dr. Bilski, 2005. The PMID's down there if you want to look at it. Summary of a scale for grading epidural spinal cord compression. So we're talking about epidural tumors, which would grow either in from the soft tissues like sarcomas, lymphomas, or from metastases to the bone or to the soft tissue, as in the present case. Here's the grade. Grade 0. There is a tumor epidural there, but there's no subarachnoid space compression. Grade 1, subarachnoid space is partially obliterated, and the cord is being compressed to a certain extent, but it's only partial obliteration. You would see the T2 hyperintensity signal partially around. 2, subarachnoid space partially obliterated. I'm sorry, 1 was without cord compression. My mistake. 1, partially obliterated subarachnoid space, but no pressure on the cord yet for a 1. 2, with cord compression, and then 3, complete obliteration of the subarachnoid space with cord compression. That is what we have in this case. This is a Bilski 3, and there it is. Did you like that? I mean, that's about as good in a nutshell review of metastases, epidural compression, et cetera. We brought in a lot of pathology principles to go with it. That is the type of case that I like to present. What case do I not like to present? I don't want to show you just a renal cell carcinoma and say, what is this? It's a renal cell carcinoma. What's a Furman grade? Oh, the Furman grade. All right, that is an entry-level question. That is not a higher-level question, and we deal with higher-level questions. All right, higher-level thought processes. Right? Not read the book, match the pictures to the book. That's not what we do in this conference for imaging or for pathology. Okay, everybody feel warmed up? I hope so. Let's move on to patient number 1. Now, patient number 1, I did draw, all right, from this conference last week, the new WHO 2020. It's not really the new WHO 2020. It hasn't come out yet. It's the C-Impact Update 6, which will likely inform the new 2020, given by Dr. Susanna Collier, my brilliant colleague in the Department of Radiology, and myself. I'm drawing this case from that conference. So if you saw it, you're going to know the answer. So you may just want to keep quiet with the chats and let those who did not see the conference have some fun with this, because it's a really good case, a standalone case. All right, what is I want to know the diagnosis, and I want to know the immunostain. Ready? So for anyone who didn't see the conference, take a stab at it. I want to know the diagnosis and the immunostain. I'm going to wait. We'll pause just a few seconds. If I had some elevator music, I would put that on. I don't know. I'll come up with something maybe for next week where we can have music while people are chatting. Okay, it doesn't look like a whole lot of chats popping up. The bottom line is, let me show you the H&E. Notice the perivascular pseudo-rosettes. Okay, so the bottom line is this is ependymoma. Absolutely ependymoma. It's a tumor. It's in the, I think hopefully everyone, I usually circle it for those who are not familiar with imaging, but here's the tumor filling up the 4th ventricle, and you can see in the T1 with contrast, with gadolinium, strongly contrast enhancing. And then if we're looking at this immunostain, you can see that the blood vessels in the center, the endothelial cells, strongly brown. The normal cellular constituents are positive. The tumor cells are negative. You can see out here in the neuropil scattered around, there's a few cells. These are going to be entrapped glia, neurons, microglia, etc. All right, and it's an ependymoma. So here's the thing though, what I wanted was a WHO, listen, I wanted a WHO 2016 diagnosis. based on the imaging and the morphology from the immunostain and the molecular signature from the immunostain. All right, let's go back quickly and look at that. This immunostain doesn't just give you a marker result, it gives you the morphology. You can see, I think the perivascular pseudo-rosettes are more beautiful, more, what's the imaging term? Conspicuity. I think they're even more conspicuous on this hematoxylin, right, with the immunostain than they are on the H&E. So the histology is telling you it's a ependymoma histologic diagnosis. But remember, not the histologic diagnoses have been modified into WHO 2016 to accommodate molecular signature, and they will be further modified in the forthcoming 5th edition of the WHO 2020 coming up. So what is the WHO 2016 diagnosis? I wanted the most precise diagnosis. All right, it's not ependymoma. That is not it. All right. Yes, Dr. Harb just got the answer correct, dead on. It's not anaplastic ependymoma because you're looking at the vascular proliferation, the contrast enhancement, which would be vascular proliferation, et cetera. It's not anaplastic ependymoma. Why? Because we have the molecular signature. If you rendered either of these diagnoses, either you just were kind of lazy, you didn't really want to think, you didn't want to deal with the immunostain, or you're living in the past. You're not aware of the proposed changes, upgrades, update, refinement, the new nomenclature for ependymoma coming in 2020. So what's the diagnosis? The diagnosis is posterior fossa ependymoma. That is part of the name. That's not a description. That's part of the name, WHO name, posterior fossa ependymoma, pediatric type, in parentheses PFA, close parentheses. Now I don't know if the close parentheses open, the PFA will be there. That's what's in the C Impact Update 6. It's still under debate. I'll emphasize that again. Some of the things that we present in the conference and present here will end up in modified form, but it's a great heads up as to what's coming. WHO grade 3, and again, you can see that's an Arabic numeral 3, not a Roman numeral. That's certainly going to change. Okay, here's the new ependymoma classification in a nutshell. We first classify ependymomas by anatomic location: supratentorial, posterior fossa, spinal cord, 3 big divisions. Then we subclassify them with molecular signature. So for the supratentorial ependymomas, there are 2 known molecular flavors: Rayleigh fusion positive with a poor prognosis compared to YAP1 mammal D1 fusion positive. And if you do not have molecular data, it would be supratentorial ependymoma NOS, not otherwise specified if you have no molecular data. If you have excluded Rayleigh and YAP1 mammal D1 fusions and you have a lot of other molecular data, you can put NEC, not elsewhere classified. Or if you turn up a different molecular signature other than these, NEC, not elsewhere classified, you have to choose one of those. In the posterior fossa, it will be posterior fossa ependymoma, pediatric type PFA, or adult type PFB. Right? And again, the 2 tumors that have an A in them, that's supratentorial Rayleigh fusion and pediatric type PFA, have the poor prognoses compared to their counterparts, and adult type PFB. Again, if you have no data, then you'll probably have to add NOS, not otherwise specified, with no molecular signature data, or NEC if you do have the data and it doesn't support either one of the more specific diagnoses. These are the same 2 qualifiers that we have been using ever since WHO 2016 for other tumors like glioblastoma and oligodendroglioma. Okay, and finally for spinal ependymoma, MYC-N amplified tends to have a worse, more aggressive course. So it is important to know the MYC-N status of all spinal ependymomas. That probably will evolve to become the highest standard of care for most precise diagnosis. If you don't have the data, NOS or NEC. Okay, quick question, very important question. How is posterior fossa ependymoma pediatric type diagnosed? How did we just do it? Did we just use next generation sequencing? No. Did we just use methylome profiling? No. Did we use a limited pyrosequencing? No. We did it by immunohistochemistry, 24-hour turnaround. All right. Estevan Ivan, absolutely. H3K27, ME3. All right, so methylome profiling, absolutely, if you have the technique, it will separate the 2 types of tumors. But you know, for most of us and out in the community, all you have to do is to run it yourself. If you don't have the antibody because you don't have enough cases to justify having it in your IHC armamentarium, send out, all right, you'll get 48-hour turnaround in many of these big labs. Demonstration of loss of the trimethylation signature at K27. All right, there is no K27M mutation in PFA ependymomas. but they do have loss of the trimethylation signature. What's the immuno? There it is, H3K27ME3. Again, if you only had a superficial knowledge of molecular signatures and you were to look at this and you see, oh, H3K27, and you go brain dead and you think, oh, that's a diffuse midline glioma. Oh, how bad would that be? Oh, that would exemplify everything that is wrong about many surgical pathologists, and I'm sure diagnostic radiologists. Superficial, quick and dirty, move the meat, move on to the golf course or whatever it is you do. All right, there it is. What a beautiful example. And this is complete loss of trimethylation with the internal positive control and the capillaries. Super easy way, endorsed by C-Impact Update 6 for diagnosing post-repositive PFA. All right, and here it is, C-Impact 6. Look under, this is the section dealing with post-repositive pediatric type PFA, loss of nuclear H3K27 ME3 expression, infants and young children, most common demographic, most have anaplastic, most are grade 3, that's what we said, aggressive behavior. Chromosome 1q gain is an adverse prognostic factor, not only this, but actually all ependymomas, it also holds here. Listen to this, 4 to 5%, a minority, but a definite minority, can harbor an H3K27M mutation. So you wouldn't be shocked. So, you know, if you were to run H3K27ME3 and H3K27M, and they showed loss of trimethylation, but there was a K27, it does not exclude ependymoma PFA. It can happen in a small percentage. All right, now look, this is an important sentence, so pay attention here. I wish we should have shown this, Dr. Kalia, we should have shown this at our conference. The nomenclature of ependymomas is being further considered by the C-Impact Working Committee 2, which is in charge of this area, and the subsequent WHO, the official WHO terminology may differ from this. Okay, so that's a qualifier. Again, we're not presenting the official WHO. It's not out yet, but it will be before the end of the year. But we're giving you a very good idea of the shape, the form it will take. Okay, everybody got that? Okay, I think it's time to move on to patient number 2. All right, 19-year-old male. All right, how helpful is that? How helpful is that? Okay, I'll tell you, we're not going to do another spine lesion. This is not going to be a spine lesion. Yeah, Dr. Zainab Harb says very helpful. It's huge. All right, it's 19-year-old, so that's adolescent to young adult, male. I will tell you, we will be dealing with a brain tumor. What is your diagnosis? What is at the top of your differential diagnosis? Dr. Harb is putting question marks. Take away the question marks, Dr. Harb. Yes, Dr. Harb is correct. Germinoma. Yes, emphatic. Did I say that? I felt like I said that at some point, that the most overrepresented brain tumor in males is germinoma. Didn't I say that at the very beginning? We're talking about Venn diagrams. Okay, now I'm not saying that this is pathognomonic, that every 19-year-old male with a brain tumor. No, of course. What we do here is we generate a differential diagnosis based on the data that we have. Now, the next slide that I show you, which is usually the next thing that we see in the real world, we get age and gender right up front. That's just like the instantaneous. The next thing we get is imaging, the pre-op imaging, which is crucial to the surgical pathologist. This may totally take germinoma off the map. I mean, if I'm going to show you, spinal cord lesion, or I don't know, it's basically gone. All right, let's see. Everybody ready? Let's see. Here's the imaging. What do you think? It's a little more complex. Do you think do we need to bump germinoma down on the list and bring something else up? What do you think? Opinions? Any opinions? Germinoma, Dr. Harb is doubling down on germinoma. All right. Okay, here we go. Dr. Cathcart says, no, we don't. All right, here's the key. Good job, guys. Here we go. Look at this. This is the pineal region. There is a pineal region mass. The key, the interesting thing here, I'll say, is look, there's also this, all right, and this, and hang on 1 second, and this. Look at these coronal T1 with contrast. Look at this enhancing lining covering of that was the septum pellucid lateral ventricle. Here's third ventricle, and then here we are back to the lateral ventricle contrast enhancing. So what's going on here? What is the most likely explanation? This is what we're talking about in terms of additional data, all right, additional imaging characteristics. It's not just anatomic location. Yes, okay, the bottom line is with all that prominent contrast enhancement, this is likely dissemination. Okay, let's go to the histology. I wanted to show more smears. Let's start with the smear, shall we? Here's low power. This is a very high quality smear. Dr. Cathcart's going to stay with germinoma. Look at the high power. Is this characteristic of germinoma? Oh yeah, absolutely. We're seeing two populations of cells, not a continuum, not a Gaussian distribution, right? A continuum, a small population of reactive T cells, reactive lymphocytes, and a very large population of the neoplastic germinoma cells with the prominent chromocenters, very ugly looking chromatin. Here's another example. One other additional feature. I'll give you a second. What is the new additional feature? New additional cytologic histologic feature that just showed up that we did not see in the first two histologic panels. Does anyone see it? What is it? Look around. I'm going to give you another couple of seconds here. All right. Yes, mitosis. Esther Ivan. Yes, mitosis. That's it. Have a look. Look right here. All right. Can you see that I'm using this fancy thing here? That is a mitotic figure in your face. It's a metaphase plate on FOSS. All right. So that absolutely goes along with a grade 4 tumor, high grade tumor. All right. You know what one of the problems with pathologists is? Seriously, it's endemic to the vast majority of us. Some of the young people coming up that have been imbued with genomic medicine, it may not be the case, but for most of us, we take too many pictures. We just take too many pictures. Here's one more. I mean, that is poster. That is textbook germinoma. Yeah. Okay. Anyway, let's move on. This is it. This is a surgical specimen. Everyone see the scale bar? All right, down here, that says 2 millimeters. This is the biggest piece of tissue right here. Yeah, it's about 1 by 1.5 millimeter, a little more stuff up here in the overright. That's all we had. Why? Why is it so small? How is the tissue obtained that it's this small? It was essentially maybe 2 by 2, maximum 2 by 2 specimen. That was it. Probably more like closer to a 1 by 1 millimeter specimen. How do you get a specimen that small? Stereotactic biopsy? No. No, stereotactic biopsy, unless it's hemorrhagic or friable and you see necrosis, generates a core. A stereotactic biopsy should be at least 3, 4, 5, maybe even, if you're lucky, a centimeter long, usually a half a centimeter long by a millimeter wide. How do you get a millimeter by millimeter specimen? I'm sorry, where's the tumor located? Is it located in the lateral ventricle, in the third ventricle, and adjacent to the third ventricle in the pineal region? What's the easiest way? When someone earlier had texted hydrocephalus, you noted the hydrocephalus. What's a neurosurgeon going to do to keep this patient from herniating and dying? Yes, Dr. Alphatal, Rasha Alphatal. All right. Yeah, yes, it is an interventional. I bet I got it too. Yes, this is an endoscopic biopsy. The endoscopy was not really done for biopsy. That was strongly suspected based on age, etc. It was done to relieve the obstructive hydrocephalus. This tumor is coating, all right, the ventral, obstructing the intraventricular foramen of Monroe. It was done to relieve it, and as long as we are in there, every neurosurgeon always, with initial presentation, is going to take a bit or 2 or 3 endoscopic biopsy. Endoscopic biopsies are the smallest specimens that a neuropathologist will see, among the smallest. The others would be spinal cord biopsies of a diffuse glioma, where the surgeon does not want to do harm, tiny little bits and pieces, and biopsies going after craniopharyngioma and ependymomas, pilocytic astrocytomas in the suprasellar region, because again, the hypothalamus, precious territory, tiny little biopsies. But endoscopic, all of them, 100%, are going to be small. Question: can you get, with this tiny little, maybe 2 millimeter, is it possible to get cytologic information, or do you just have to freeze it if the surgeon's asking for intraocular section? Well, I just showed you it's possible. It's beautiful. All you really have to do is a drag or a touch. Dr. Cathcart says do a touch. Do a site, yes. You can, look, listen, here's how you work it. Here's how you work it. Same thing for tiny stereotactic biopsies. Pick up the specimen gently with your forceps, touch it 1, 2, 3 times, or drag it back and forth. Drag it back and forth on the slide, then slide straight into the alcohol. If it's a tumor that sheds, like germinoma or a metastasis or lymphoma or oligodendroglioma or central neurocytoma, those will all shed cells. And then you can freeze it, and you need to make sure that you cut additional sections from that frozen for immunostains. Have the histotech right on the sheet. Please cut 10, 15, 20 unstained in the morning when it comes out of the FFPE, because if they have to face the block, specimen's done. All right, this is bread and butter 101. But you know, a lot of people listening to this conference are going out into the real world July 1 really soon, less than a month. Don't forget these lessons. All right, here's the permanent section. And yeah, it shows the same thing, but don't you think that the cytologic prep was actually better? I do. What's the immunostain? This basically locked it in. This proved it. Germinoma is our diagnosis. Based on the histology, age, anatomic location, it is germinoma 4+ over. Yes, Dr. Harb, OC34, that's exactly what it is. All right, here's our diagnosis. Yeah, Dr. Alphatal got it right too. Brain designated interventricular mass. Okay, this came out of the OR, designated by the surgeon intraventricular mass. Which ventricle? Lateral, third, fourth. It's very nonspecific. So I added, in parenthesis, pineal region mass with CSF dissemination to third and lateral ventricles by imaging. I added that because it is the truth, and it enhances the value, not only the honesty, the clarity, the value and the detail of my pathology report. And that's all I have. That's all I do. That's all we do as diagnostic radiologists and diagnostic surgical pathologists. Your report is you. That's it. That is your product. And if you don't take pride in that and correcting spelling errors and being precise and being accurate, oh my goodness, you're not really designed for this life, and you're going to get burned. All right. Anyway, moving on. Endoscopic biopsy of right lateral ventricle. All right. Germinoma. Comment. We'll always start with H&E paragraph. H&E stain, cytologic smear preparations, frozen section, and formalin fixed paraffin embedded tissue section show characteristic bimodal cell population size region germinoma, comprises reactive lymphocytes, large germinals positive for OC34. Second paragraph. Germinoma is consistent with pre-op MR imaging studies. Large mass, centered pineal region, associated with smaller lesions throughout third lateral ventricles, consistent with CSF dissemination. Listen to this. This is a great concluding paragraph. The patient's age, gender, anatomic location, clinical behavior, dissemination, morphologic features, and immunophenotype are all congruent with germinoma. I think it would be comforting, it would be reassuring to the primary care physician, the neuro-oncologist, the radiation oncologist, that the pathologist has done their job, done their due diligence, and checked for incongruencies, checked for red flags in all 8 data spheres of the Venn diagram model. All right, super quick. CNS germ cell tumors, 3 big categories. Germinoma, standalone, single most common. Non-seminomatous germ cell tumors, embryonal, yolk sac, choriocarcinoma, teratoma, and mixed germ cell tumors. All right, only germinoma and teratoma are usually pure. Usually the others are mixed in various combinations. Most common tumor of the pineal region, germinoma. All right, biphasic cell population, positive for all 3 of these markers. Let's look at them. There's SAL4, and essentially stains all of the germ cell tumors. It's going to be weakest, sometimes negative in choriocarcinoma, stains all the others well. There's OC4 or OC34, CKIT or CD117. Look at PLAP. Back in the days when I was a fellow, neuropath fellow at Duke, PLAP is all we had. It's all we had. This is a typical PLAP. Now, is this the PLAP that you see in Peter Berger's textbooks? No, you see every single cell beautifully positive. I'm not picking on Peter. He's my mentor, the most experienced, most knowledgeable surgical pathologist in the entire world. All right. No, it's because you pick the 4-leaf clover. All right, for the textbooks, not reality. This is the reality of PLAP, and that's why it didn't even make my table. It didn't even make my table of practical germ cell tumor markers, because it is so unrobust compared to all of these. So you can see SAL4 positive, essentially all, very weak, maybe negative choriocarcinoma. OC4 is also positive in embryonal carcinoma, not just germinal embryonal. Well, guess what? You could usually tell the difference between germinoma and embryonal carcinoma on an H&E. All right. Again, CKIT, yes, strongly positive in germinoma. Embryonal carcinomas, 4+ positive for CD30, AFP, and yolk sac tumor. Now look at beta HCG, human chorionic gonadotropin. It is 4+ positive. It's like the defining signature of choriocarcinoma, obviously, but it can be positive to a greater or lesser extent in all of the other germ cell tumors because of the syncytial trophoblast, and it can elevate, usually to a lower degree, the serum level of beta HCG and all of the others because of the syncytial trophoblast, which are variably present. Okay, patient 3. Let's move on. We still have, we've got 6 minutes. That's a ton of time. Let's move on to patient 3, 30-year-old male. All right, we're staying with the young adult and go with the male gender. Here we go. This is I'm sorry, this should have been an IPR diagnosis. Anybody got a diagnosis for this? We have to have something that everyone can get right. And Dr. Gilbert got it right. Good job. So did Dr. Alphatel. Meningioma. All right, and Dr. Harb. Ashley Holloman. Yes, welcome, Ashley. Meningioma. Great. Okay, guess what? You don't even get any credit for that. Hang on, because you guys are too advanced. I know you know that. So meningioma. Okay, what's the histologic subtype? Let's try that. Let's bump it up one. Believe it or not, this is something a lot of people get wrong, and I don't know why. All right, transitional, Dr. Alphatal. Yes, it's transitional. For some reason, people want to call this meningothelial. Meningothelial is syncytial. There's no whorls. It's like a sheet with no borders. Transitional, think of it as a transition between meningothelial, the sheets, and the fibrous and fibrous, right? And so if you swirl them all together, all right. I'm sorry. Oh man, I totally messed that up. I'm trying to finish on time, so I'm hurrying too much. All right, WHO grade. I want the grade. Did anybody see that slide, by the way? Maybe I changed it back. Okay. Okay, I wanted everyone to say grade 1 because you've memorized these 13 morphologic subtypes based on H&E, right? It's 9 WHO grade 1, 2 WHO grade 2, the 2 that start with C, clear cell and choroid, and 2 the WHO grade 3, or the anaplastic, which is rhabdoid and papillary. And I wanted you to fall into the trap and say grade 1. In fact, it's atypical. It is atypical. Here's the point. Listen, there's a point. The point is, just because you see beautiful whorls in a meningioma does not mean it is grade 1. You still have to look for brain invasion and for all of the atypical features, small cell formation, sheeting architecture, prominent nucleoli, etc., as well as mitotic figures. You still, because any of the 9, quote, WHO grade 1, end quote, subtypes, histologic subtype can be bumped up to a grade 2, maybe even a 3, but to a grade 2 based on these other features. Everybody got it? What it means is be careful, be diligent, spend the time. Okay, what would have helped us, what would have helped immensely for us not to fall into the trap? In this particular case, do you think I was even, this was my case, and when I went up to Frozen to do the Frozen on this case, do you think I was even thinking WHO grade 1 meningioma? I wasn't even thinking WHO grade meningioma. Why? Imaging. Yes, good job. Look, this is the imaging of the case. Does that look like a beautiful, happy meningioma to you? No, these are beautiful, happy meningiomas. Homogeneous, avid contrast enhancement, smooth, convex interface with the brain. Look at the beautiful, smooth, convex interface. Look at ours. It's not beautiful, it's not smooth, and look at the edema. That's the hypointensity surrounding it. Now, ours is in this group. This is the WHO grade 2. Look at these patients. Lobulated interface. That's the mushrooming sign. Fuzzy interface. Frequently, it's invasion. Marked brain edema. Atypical meningioma. 6 mitosis per 10 high power field. 9 by PHH3. KI of 67, 23%. There's the automated quantitation of the KI. Okay, we're not going to go through this because of time. All right, it's just talking about how it makes sense. And there's the 2 references for the mushrooming sign. Okay, we got to get through case 4. We may run just a couple minutes over. Bear with me. It's a great case. I want to finish one conference. And this is the last case. 61-year-old female, pre-op imaging. I don't have the imagings outside case. Comment, these imaging findings of multiple rim-enhancing lesions, vasogenic edema. Everyone got it? Okay, here's the histology, H&E. All right, what you are looking at are PMNs, polymorphonuclear leukocytes, acute inflammatory cells. Here's another section, acute inflammatory cells. All right, coming in from the outside. Here's the acid fast, the AFB stain. I put the positive control in the upper right. You can see the little red snappers, as we call them. This is only 20x, the big magnification, but we wouldn't be able to see it. Negative AFB, I'll just tell you, Here's the Gamori methenamine silver GMS fungus, and there's a positive control in the upper right. You would see it as black. If this were aspergillus, we don't see it. This is a PAS fungus. You can see again the polys in the background. There's a positive control PAS fungus. No hyphae, etc. There's another PAS fungus. You can see the thrombosis in the blood vessel with the polys. There's no PAS fungus is negative. They did not, the outside institution did not run a gram or a fight. They were not performed. What's your diagnosis? I'll give you just a few seconds. Just a few seconds. And now I'm going to finish this up quickly. There is a payoff. Okay, I'm getting abscess. Okay, abscess. Why would I do that? Why would I show you an abscess? Why would I do that? Why? My case is, yes, Andrea Gilbert, glioblastoma with PMN infiltrate. Listen up. Dr. Andrea Gilbert, neuropathologist, UT San Antonio. Guess where she trained? Here at the Baylor MD Anderson Cancer Center, Neuropathology Fellowship. Nailed it. This was the key image. Do you see the polys that I was mentioning? Look, you see here, these, look out here. These are not polys. This was the image. Okay, was that tricky? Was that unfair? Are you mad? Yeah, you know, is it unfair? All right, you know, I say this all the time, but it's so true. I cannot, in my wildest machinations, I cannot create traps as devious as nature and cancer will set for you out there. In imaging as well as pathology, you better be on your toes every second. You better be skeptical. It's fine to form a diagnosis, but then you have to be critical. Question your own diagnosis. All right, 13 outside slides. Glioblastoma, IDH wild type, grade 4. There's all that, yada, 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 yada. I'm moving pretty quickly here. It's, yada, yada. All right, I'm sure I didn't show you this image. All right, yeah, there's a glia, and I'm sure you're saying, well, if you showed me that, well, guess what? The outside pathologist didn't hone in on that. They ordered, not up front, not at the beginning, they ordered all of these immunostains. Why? Why did they, I'm sorry, special stains. Why did they order bug stains? Because of the polys. Why did they do that? Because they didn't know, listen, they didn't know there are 22 histologic patterns that can predominate, particularly on a small biopsy, stereotactic biopsy, and glioblastoma. And look, there it is. It's been on the list the whole time. From day one, I think I started this list with something like 12 histologic patterns, right? Inflammatory, and that's just my term. That's my term for when there are a lot of PMLs, acute inflammatory cells. Some glioblastomas have them, all right? Others don't, most don't. When they do and you have a small biopsy, you can be led down the path unless you are sharp. Quick question, let me ask you a quick question. Now you may be saying, but wait a minute, I would not have fallen into that because I would have looked at the pre-op imaging, which would not have shown a perfectly smooth, even contrast-enhancing ring. So a smooth, even ring. Can glioblastomas do that? Yes, of course they can do that. Now, the restricted diffusion, maybe, not usually. All right, that's a tougher sell. But inflammatory, just be aware. Okay, we're not finished the case yet. Give me 2 minutes. 2 minutes and I'm done. This is the point here was that was not the only interesting thing in this case, believe it or not. All right, look at this. This is another high power H&E. What do you see? I'm just going to give you interest of time. I'm going to give you about 5 seconds. You don't have to chat. Give you about 10 seconds. Look at it. What additional features that we have not talked about do you see? All right, Zainab Harb's going with SIGA-like. I like SIGA-like. The big pink cells. It's something else I'm going for. Okay, here we go. Histology and cytology. Let's talk about, yes, Dr. Cathcart got it, Creutzfeldt astrocytes. Let's look at histology. All right, number one, there's the vascular proliferation, which goes along with the glioblastoma, not so much with abscess, really, okay? So that was there. But I really want to talk about cytology. So when you look at an H&E, you definitely first look at the bird's eye view, 30,000 feet, all right? I know there's a lot of people who've forgotten what that's like because we can't fly anymore. We can't go to meetings. But you know, at 30,000 feet, that's typical cruising altitude. You look down, you get the big view, the big picture. That's where you see vascular proliferation, necrosis, big things, normal brain, stuff like that. You're looking for it. This is what I wanted you to see. There's 2 cells labeled 1 and another cell labeled 2. Look at those cells. See all the tiny dots in the cells labeled 1, and then they're a little bit bigger and more irregular in 2. The tiny dots are granular mitoses, and the big thing is Creutzfeldt astrocytes. Now, these are buzz terms for demyelinating disease, right? And particularly all demyelinating diseases, including progressive multifocal leukoencephalopathy and monophasic demyelinating disease, etc. Creutzfeldt cells, also called Creutzfeldt astrocytes. Can they occur in glioblastoma? Absolutely. Here's Dr. Ballister and Dr. Sikowski. Creutzfeldt cell-rich glioblastoma, absolutely. It's only a diagnostic dilemma if you don't know about it. All right, and here, look, there's a picture in the middle. There's the Creutzfeldt cell glioblastoma. A little more erudite paper, if you will, in brain pathology. Creutzfeldt astrocytes may be seen in wild-type GDM and retain expression of DNA repair and chromatin binding proteins. What I love about this, if you look at that author list, you're going to see in the affiliations, Pathology Genomic Medicine, Houston Methodist Hospital, Pathology Laboratory Medicine, UT Health Science Center, and University of Texas MD Anderson Cancer Center. Isn't that cool to have a Texas Medical Center-wide collaboration? We truly are a family. All right, and here's the figures. See, Creutzfeldt astrocytes across the top on the smear preparation, granular mitoses across the bottom. All right, and you can identify the smear. And then I'm not going to go through this, but then here's what spots it up, looking at some of the tumor markers, etc. Isn't that just beautiful? Yes. Okay, granular mitoses, Creutzfeldt astrocytes. Is it on the list? Was it on the list? What do you think? Yes, of course it was on the list. But see, you can memorize a list, but until you see a case, till you have a case, it can still take you down, which is why we do this conference. Okay, I'm a minute 06:09. I'm going to stop there. Thank you to everyone for coming to the conference. Follow me on Twitter if you want to see challenges, and I have a YouTube channel now, which I'm in the process of loading up. Thanks to everyone for attending, and I think we will stop the conference there, and I hope to see you all next week. Thank you.